vendors are a good resource because we're able to be the expert in the field, as opposed to if it's a hospital, they're going to have to hire a lot of different experts. And when they do try to hire that expert, it's going to cost them even more. So many hospitals are struggling with staffing now. That's why they're turning to vendors, because they can point at us and say, that's your problem now. So it's not our problem anymore.
Hi, everyone. Welcome to this week's episode of Let's Talk Solutions, Candid Conversations with Healthcare Leaders. I'm Becca Leaf, Director of Business Development here at HHS.
And I'm Amy Fritzer, also Director of Business Development for HHS. And today we're going to be discussing support services and a lot of the misconceptions around support services within a healthcare facility, their functions, the importance, and also what benefits they do bring to a hospital.
Today we are joined by Ray Delk, who is the EVP for the Western Division here at HHS currently, but he's actually a former COO of an independent hospital in the Southeast. Let's get started. Well, thanks for joining us, Ray.
My pleasure. It's great to be here.
So your background is so interesting, Ray, because you've been on both sides of the aisle, so to speak. So you've been in the executive, leadership team for a hospital, and then you've been on our side, of course, where you've been reporting to the hospital administrator in terms of being responsible for overseeing the outsourced program within that facility. You've got a very interesting perspective, and we'd love to learn, how did you go from the administrative side in the healthcare realm to what you currently do?
Well, quite honestly, my previous employer made it pretty easy for me. And that was, I was part of a small independent health system in East Texas. And our system looked for a partner for probably a couple of years, trying to find someone to join up with, because quite honestly, small independent systems or even independent hospitals really are going to be a thing of the past. And I would say within the next 10 to 15 years, there's going to be maybe 20, maybe a little more large health systems across the U.S. And everybody's going to be part of those 20 to 25 health systems. And just like everyone else, we were looking for a partner. And what's odd is I was actually the only C-suite executive that was involved with all the due diligence, with all the site visits, going to all the different potential partners. And I did every tour. I did all the meetings. I did everything. And so once we found a partner, the day before they started, they in essence let the C-suite go. They wanted to bring in their own team, which is fairly typical. We were prepared for that. So anyway, within 24 hours, I had a call from Scott Alexander with HHS, because HHS was my EVS vendor. And Scott said, and we had been working pretty closely together on some other issues, just going through some of that due diligence and some other issues we had. So I knew Scott pretty well, and Scott said, we'd love to have you as part of our team. You kind of bring a different perspective. You bring the other side of the table, just like what the question was.
Exactly.
You kind of know what hospitals or systems are looking for, what drives them, what are they truly looking for, and then what can HHS do a little bit different that will help us increase our business. So that's pretty much how I got into the other side. Some people in the hospital call it the dark side. I don't necessarily call it the dark side, but it's definitely the other side for sure.
Well, so I want to back up for a second, because we want to talk about support services. But before we jump into that, because I want to get your opinion, especially as an administrator or previous administrator, let's define what support services are, because, there are common misconceptions around it. Anyone who's listening to this, I want them to completely understand what we mean when we talk about support services. So within a healthcare setting, both, clinical and non-clinical support services, how would you define those, Ray?
How we defined it, and I was in a not-for-profit organization, so and they're slightly different than for-profits, but I can tell you from my perspective, support services in a general sense is anything that supports patient care but does not necessarily touch the patient or have direct interaction, whether it's administering something, whether it's doing an x-ray, et cetera. That's what your true support services are. So you're talking about your EVS, your food service, transport, biomedical engineering, facilities management, plan ops. Those are your true support services. And then, as you said, Becca, the other side of that, support services, most people call them ancillary services. And the ancillary services actually do a type of patient care, even though they may not directly touch the patient. Examples would be your lab, radiology, respiratory, pharmacy. They do have some light touch of the patient, maybe administering a med or maybe doing a blood draw, but they're not necessarily caring directly for the patient. They're doing tests.
Right. And therefore they don't require a medical license or certification of any sort. Some
do, some don't. It just depends on what they're actually doing.
Okay. I would imagine you can't touch a patient if you don't have a license of some sort.
Yeah. And true support services, that's a great point, is most of those have no certification in terms of patient care. So there are some certifications that are out there for, biomedical, for EVS, for food service. A dietitian would be a good example.
Exactly.
They don't necessarily care for the patient, but they are in patient care. So, a licensed dietitian does have to have that ability to speak on that nutritional value. So that's really the big differences.
And then, so when it comes to support services, and like we were just talking about, you've been on both sides. I mean, what do you think the most important thing is, in the executive leadership team? What's the most important thing to them when it comes to support services? What is the deciding factor for them on the best programs to, install in their facilities?
Well, and I can tell you, I think there is a slight difference between a for-profit organization and a not-for-profit organization. And those differences are minor, because really the important pieces or aspects are important for both sides. However, first and foremost, it's going to be cost. You're going to be told that patient care, and I don't doubt this, but we will be told that patient care is first and foremost the most important. And I don't doubt that. That's usually pretty true, but I would say that would be 1A, and then 1B would be, how can I cut costs to do this?
Right.
And so, because healthcare, you ladies know that healthcare reimbursement is what drives everything, and reimbursement every year is being cut by every insurance company. And self-pay is going up and up and up, despite Obamacare and some of those other plans that were designed to help the uninsured. So for any
that's
organization,
a whole other topic altogether, by the way.
Absolutely, and I'm not going to be your person there. I'm a little bit too opinionated on it, but I can tell you, first and foremost, they're going to say patient care. Secondly, or actually 1B is going to be the cost of those services. And when you Ray, sorry to interrupt. So when you say the cost of the service line, what do you mean by that? Like, what are the costs associated with it? Well, the costs that are associated for, and we'll just stick with EVS, the costs associated are salaries, employee productive wages, employee wages. Secondly, is going to be your management wages. Third is going to be your TIB, your taxes, insurance, and benefits. And the benefits piece, in particular for the not-for-profit side, is where they are spending so much more money than many of your for-profits, and even in a lot of cases, even with your vendors, just because their benefits historically have been very rich. I can tell you that when I left my former employer, I had over 700 hours of sick time built up. Wow. And if you stayed with the organization so many years, when you retired, certain levels or percentages of that would be paid out. So it'd be almost like a bonus when you retire.
Wow. So that's amazing.
Yeah. And then the other piece is going to be your 401k type matches. We actually spoke to a large for-profit organization just a couple of weeks ago, Ward Wilson and I, and they actually do a 9% match on 401k. That's unheard of.
Amazing. Yeah.
Wow.
You might see a 6 here and there, a 6% match. But so when you start putting all these benefits together, most of them do like a PTO buyback. So if you save up your PTO, you can do a buyback twice a year. So there's all these little benefits that are in there that not-for-profits typically have built in, just because it's just something that helps them retain. And they're quite honestly, they're scared to take those benefits away because of what the results may be.
And do you think a lot of that may have to do with the fact that a lot of these non-for-profits, for example, are perhaps the largest employer in their communities, and they really, being not-for-profit, they give back a lot of charity care and do a lot of work within the community. So they don't want to lose that perception at all, or have that tainted in any way.
Absolutely. That is absolutely true. In fact, we've been working with some new customers as of late that are concerned that, unions right now are kind of back in the spotlight, trying to unionize various staffs in various markets. And so we have spoken to a couple of potential customers that did express a concern. Hey, if we did this and our benefits changed dramatically, that could lead to something, catastrophic for us in terms of union, or worse yet, getting into the media. Just because right now it's become such a game of, I'm entitled to this, so therefore, if you take it away, I'm going to go
somewhere
make
else.
it bad for the hospital. Correct. So, and I'm neither here nor there with that. It's just a fact. It's just something that we are seeing quite a bit. A couple of things I want to add. The second most important, besides those two that I already gave, I believe would be the ability to staff. So many of our partners, as well as our non-partners that we're trying to recruit, so many of those right now are struggling with staffing, just because the market is so tight. This is a hard job. It's a very hard job. And when you start looking at COVID and you look at how hard people are working, and now hospitals are basically, I would say 80% of my hospitals now have a higher census than before COVID, just because now they're trying to catch up.
Really?
Yes. It's pretty amazing, just, because all the business went from where they make their money with outpatient surgeries, with GI procedures, et cetera. All that was put on hold for 8 to 10 months, and now it's all back. So, so many hospitals are struggling with staffing now. That's why they're turning to vendors, because they can point at us and say, "Hey, that's your problem now." So it's not our problem anymore. It's now your problem. So, and then thirdly, and I think this is an important piece, and I know with my former employer it was very important, is vendors are a good resource because we have the technology in the background to be able to do, whether it's team member training, we're able to be the expert in the field, as opposed to if it's a hospital, they're going to have to hire a lot of different experts. So they'd have to have an expert in EVS. They'd have to, and typically they try to get that through the director. And when they do try to hire that expert, if you will, it's going to cost them even more. So for me, that's really the top four. It's going to be the cost piece, as well as what's best for the patient care. Secondly, ability to staff, and lastly is just being that expert of knowledge for that hospital.
Yeah, I mean, I agree with that. I mean, I think over the years, I've been in this position for 9 years, so I've talked to a lot of administrators and executives all around the country at various regions and whatnot, and they always say, a lot of times when they've needed assistance, I just don't have the time. Like, I can't focus on this. I've got to work on this, or I've got, and now the last year, Ray, as you were just talking about COVID and the difficulties that came with that, as we all know, I just had a conversation last week, or maybe it was a couple weeks ago, and he was at a hospital up in the Midwest, upper Midwest, and he was like, I've spent more time trying to hire, because like you said, staffing is a big issue, recruiting is a big issue, and trying to find a director that fits within the facility, the culture, knows the background, is an expert and stuff. He's like, I've spent more time on that than I have been able to work on the facilities and the clinical side and the other side that I need to, focus on as well. And so I think a lot of the benefit of having a vendor or partner in that is that, like you were saying, they can focus on the patient and the clinical side, and we can focus on the non-clinical side.
Absolutely.
Or the vendor can, whoever it happens to be, right?
Correct. That is 100% accurate because, just like our TMR, as well as our directors and our managers that are responsible for recruiting right now. And HHS has now developed the rapid recruiter team to assist us in various markets. But, all that is driven straight by, hospitals need to focus on their own clinicians, whether that's doctors, whether that's nurses, respiratory techs, lab techs, et cetera.
Right.
And EVSs or food service are always the lowest on the totem pole. And so when you're looking for resources, if I'm going to schedule interviews today and I'm a hospital HR department and I've got my choice between 5 nurses and 10 EVS techs or food service techs, I'm going with 5 nurses because that's what pays the bills.
Right.
It's just, they don't think about the downstream effect of not having those people. It's
with
just,
HCAP scores. And
correct.
Exactly.
Absolutely.
So you mentioned benefits. I kind of wanted to talk about that a little bit because something I hear over and over again from administrators too is, when you tell them, okay, when you're going to outsource, so currently, maybe the situation is they're in-house, so they have all of their EVS staff that they're employing themselves. And then they talk about outsourcing their support service line, and all of those staff members are going to come onto our payroll, which means they're going to come onto our benefits. And I think the reaction is definitely different to your point with the nonprofit versus for-profit. But what do you think are the initial shock or sticker reactions when someone says that they're going to move your employees onto our payroll instead?
I think the administrators or the team that's responsible for making that vendor decision, I think they're well aware of what those changes are going to be, and what it's going to involve is how willing are they to go all the way through with that RFP and making the change, because I think they know up front, our benefits are too rich. And this costs us too much money to do this. Right. So therefore, this is the right thing for us to do as an organization. And then that's where the difference between the not-for-profit and the for-profit is. The not-for-profit is a lot more hesitant to go through with that step because it is going to impact their people, their team. Whereas typically the for-profit, they recognize what has to happen. And they're being driven typically by a corporate office saying, we get it, too bad, make it happen.
Right.
And so I think that's where the difference is. But I think they know that on the front end. And, we typically do see a little bit of pushback after we're there, because when the team members start utilizing the benefits and they're different, and I'm not saying they're worse or better, but they're different.
They're different.
And how they operate are different. Exactly. And that's where they will go back to the local administrators and say, hey, our benefits aren't as good. Well, that's not necessarily the truth. They're different. And how they have to apply or utilize them is different. So, and to me, that's the key in the communication on the front end during the sales. Is letting them know, hey, you're going to have some differences right out of the blocks. And here's what we do. Here's how it operates, and help them understand so that, because those team members are used to going to the VPO or the COO or whomever the direct report is, and just, whatever the complaint is, going to them and complain. And so I think as long as we're doing that on the front end, it's not as big of an issue. So that's kind of where I think it falls.
Yeah, that makes sense.
So just to kind of make a clear distinction, I guess, what is the difference, Ray, of an outsource versus an in-source support service?
In-house?
In-house.
Yeah.
Yes, in-house.
Yeah,
that's what I meant. Is it Monday morning?
Almost. There's actually two different programs that HHS operates as an outsourced program. There's two different roads that you can travel. One is what we call a package deal. That's where the management team, everyone, the team members, et cetera, are all part of HHS's payroll. That's called the package program. Then you also have the management only program where HHS will assume only those managers. So if you have a hospital or organization that is struggling with giving up those benefits for their friends and team members, their colleagues, we can provide that management only option. And what the advantage for the hospital is, okay, your team members aren't changing. They're not going to change their benefits, so nothing's going to be taken away in their perception. But at the same time, they're going to get the full HHS program in terms of the managers are going to have our training. The team members are still going to have our monthly training. All those things are still the same as with a package, except that the only people that are going to be on the HHS payroll are the managers. So it will cost the hospital a little bit less, or will cost them less than if it was a full package. And, because we obviously have to pay for all those costs whenever we take that program. So, and then the in-house program is basically the hospital is responsible for all those services themselves. So that's kind of in general the basic difference.
So with management only, is the hospital still on the hook for staffing?
Yes.
So that's the downside.
It's still run through their own HR. And one thing that I see, I'm not going to say we, but one thing that I see is those that do the management only, and some of the large for-profit, it allows them to feel like they're still in control of staffing. So you start looking at flex staffing. If the census goes up, we need more staff. If the census goes down, we need less staff. Right. So typically when you have the management only, in many cases, you have the administrator calling the director saying, hey, our census is down, so send 3 people home. Whereas they don't feel that they have that luxury when it's a full package deal.
Yeah.
Even though they do. And a lot of our partners now have a flex census type package where we do that. And our directors are instructed on how to do that. However, it still allows those customers to feel like they have control of that, as opposed to they feel they lose that control when it goes to a full package and we have the team members. So even though we do whatever, typically whatever they ask us to do, it still leaves that control in their hands. Yeah.
I mean, you've hit on like the big hitters of what administrators care about and then what that would look like in-house versus outsourced. I keep wanting to say outhouse because I said that last time. It's terrible.
I do that all the time too.
I think we all do.
But what do you think, if you had to guess, especially from the experience you had and the colleagues you have from being an administrator, is the number one hesitancy to outsourcing? If you had to pick one of those things.
To me, the number one hesitancy is, and I'll be honest, I thought this as an administrator myself. How can I pay a company to hire all the employees and do it cheaper than I can do myself? Because the company has to be making money.
Right.
Bottom line.
Right.
So then at that point, when we share, okay, you're saving from this in terms of the team members, the benefits, not the team members, but the benefits and just some of those rich benefits that go away. Well, then that flips the switch over to, well, I don't want my team members to lose benefits. So to me, the number one is, how do I pay another company, which they have to make a profit? How do I pay another company to do the same exact thing with the same number of people, but it's going to cost me less? So to me, that's the biggie.
So how do you combat that?
Well, it goes straight back to, okay, is the value that I'm bringing myself in keeping those departments in-house is that benefit of keeping them in-house, does that offset the benefits of outsourcing?
And what would be those benefits?
The benefit 100% is cost. Because and quite honestly, when you start looking at a lot of the costs, it's, when you've done P&L on the hospital side, when you outsource that, all you're seeing is the check going out to the vendor every month. So all you see is a lump sum. You never see, okay, if they were still in-house, the only cost you're seeing is your supply cost and your labor cost. You're not seeing those benefit costs. Now, every hospital in their P&L, they have a percentage that's allocated for benefits. However, most hospitals or many hospitals are self-insured. So it's through a third-party administrator, a TPA. And so whenever you have a catastrophic claim, that's when you start seeing the black, or actually the red numbers, hit your P&L. And so if someone has some sort of catastrophic, car wreck, what disease state, that's where you start seeing those benefit numbers go up even higher.
Right.
But you're not going to see an immediate reduction of your 401k. That's just something that happens above the P&L. For the administrator, that's kind of the piece that's hard for administrators to see, because it's not they don't see it as like you do your home checkbook, where you're writing a check to the utility company or to the cable company or to the car company. You don't see those checks going out.
Yeah, it goes in different buckets.
Correct.
Versus just that one particular department, for example. Yeah, that makes sense.
Yes, and there's so many buckets above the P&L for a department. So there's one big benefits bucket that all that kind of stuff goes into. And quite honestly, they don't want to go through, if they've got 500 employees or 800 employees or 2,000 employees, they don't want to go through and try to separate that out by employee, by department.
Right.
Quite honestly.
Plus, there's the whole idea of instant gratification when it comes to the cost reduction too. Like if you want cost reduction, you want to see it reflected on your next bill, but it could be a matter of, hey, your quality of care is going way up and your HCAP scores are going way up now. And so now you're going to get more money for your facility.
And that's that's why we have such a push on the ops side for EVS in particular with HCAPs and turn times, because that's the things that we can go back to them and point to, okay, your turn times are 55 minutes. So in your large, busy organizations, for every minute someone sits in the ER, being a hold, that's money out of their pocket. So that's the benefits that we can put immediately back on their bottom line. And HCAPs, quite honestly, when you drive or you dig into HCAPs and if your HCAPs for EVS are low at an organization, if you really dig into it, the percentage amount of reimbursement that affects is pretty minuscule. Now, when you put them all together, it's fairly significant. So it could equal 1 to 2 to 3%. So when you have a large organization and all that's your Medicare funding, Medicare is typically the biggest driver. And so whenever you get into that Medicare reimbursement, and let's say 60% of your business is Medicare, that minuscule percentage will make a difference in how much they collect annually. So that's why it becomes such a big deal.
When you say put them all together, are you talking about multiple facilities within one system?
No, when I'm putting all the various components, because you also have your surgical site infections, you also have hospital-acquired infections.
Oh, and you're talking about the HCAP survey?
Correct.
Got it.
Yeah, I got you. Okay. Yeah, that makes sense.
All the different pieces it's called value-based purchasing, VBP. So your VBP is what really drives that reimbursement.
Okay.
So that's why HCAPs are so important.
Right.
And I would think, kind of echoing on the cost thing, Ray, would be like you were talking about all these different buckets, right? And a lot of times the facilities don't realize what they're spending for that particular service line or that particular department. And I would think another benefit would be kind of that financial stewardship piece where, if you compare the cost of like the department, let's say EVS, whatever support service it would be, capturing the labor the TIBs, the chemical costs, the equipment, all that, and putting it into one that the hospital can see, oh my goodness, like we actually spending more than that. So you're right. Like we would have that transparency for the hospital, and they could actually see what their true spend is.
Correct.
Right?
And I can tell you in my years at my former employer, I did 4 different consulting groups that came in because my EVS was HHS, my food service was a different vendor, and then biomed and plan ops management only were a third vendor. And so I did 4 different iterations on what the true cost should be in terms of what we're paying for that. And if you paid for it in-house versus what you're paying to do that, because HHS does not do this from anything that I've ever seen, whether on the hospital side or whether in the HHS side. But 2 of those vendors, or those other 2 vendors, we found over $1 million of opportunity if we were in-house versus what we were paying a vendor to do that.
Really?
So more and more organizations are bringing in those consultants. PricewaterhouseCoopers, a big one, Huron, FTI, so you see all these big names that come in and do that. And like I said, I never had an issue with HHS when I was on the hospital side. But I did. Here's a quick story that'll kind of make you understand. Looking at the biomedical side, they also, I was fortunate enough, I had someone that was trained in MRI CT. So I did not have to call the company that built the MRI or the CT. I had my own guy that could fix that. And I mean, most places don't have that. And so my downtime was minuscule, but in looking at that, and I still had about 22 pieces that were on the company that made the equipment that we still outsourced to them because the rad director, the radiology director, really wanted to use the company because she didn't trust the vendor. And so when they found out that we had brought in a company to look at the cost, because we even included them in those costs, the company actually called me. This wasn't the vendor, this was the company. The company called me and said, "You are such a good a good partner. What we're going to do is effective immediately. We're going to reduce your contract spend for those 22 pieces of equipment by $650,000 a year."
Wow!
Just because I'm a good guy. It was.
Doesn't that make you feel like it's all seedy? That's awful.
Well, exactly, and that's what I said. I said, "Well, I appreciate that, but where were you the first 3 years of the contract?" So, at the point they heard that we were looking into it, and then I was doing the spreadsheets to look at the cost of taking it to my vendor versus leaving it with the manufacturer, is when they started saying, "Oh, well, we can actually do a little better." So it is. It's, and like I said, I have never experienced on either side of the table. I've not experienced that with HHS. I am true blue with HHS. We do not do that. But there's a lot of companies out there that the whole philosophy is get what you can while you can get it.
So with the consultant, I mean, that's very interesting. I hadn't really heard of that, and I love that idea. But do you feel like when you were negotiating your contracts and getting proposals from all of those 4 different vendors you had for those services, was that kind of an exercise within itself for you to visually see how much you were spending within that department?
Absolutely. And you ladies know as well as I do, most organizations, they back their ears when you start talking about an RFP. They will threaten an RFP.
Or getting bids in general.
Yes, they will threaten it.
They will threaten an RFP, but they don't necessarily want to do an RFP.
Right.
Because of that very reason. It's a lot of work. It is. And particularly if you do all that work and you're pushing, say we have someone pushing us saying, "Hey, we're going to RFP and you better lower your costs." And we walk back in and say, "This is our cost," because we don't have any place to lower it anymore. And so they keep threatening and they're not so nice about it. And then at the end of the RFP, they find out, well, HHS really is the lowest and the best value. So, they've wasted. I mean, it's at minimum a 6-month process.
Yeah, exactly.
Yeah,
if you do it correctly.
Right. And there's like one dedicated employee running the whole thing. So you're basically paying someone to do it too.
Absolutely.
So, and Ray, so why do you think that hospitals kind of bulk at, even though, especially if like whether you've been in-house for a really long time or you've been with one sole vendor for an extended period of time, maybe 5 years, 10 years, however long it is, that long-term relationship. And, especially now after, COVID and everything else, we all know the struggles that many hospitals and facilities have gone through. They're all trying to recoup right now. They're trying to get back open, get back to full scale. Like you said earlier, their census is up in a lot of cases, even higher than it was pre-COVID. So they're taking a closer look because every dollar counts, right? So you're looking at every dollar and you're going, man, do you look at the contract and say, you know what, maybe we can cut this or whatever. But as you also mentioned before, they don't see every cost. They don't see every line item. They just see this is what we pay a month. So it would kind of make sense to, especially if you've been long-term one way or the other, let me put it out there and see what other bids I can get or who else, whatever the vendors are, where it's 2, 3, 4, 5, and kind of go through that process to evaluate, the services, the costs associated with all that. But why do you think so many hospitals won't go through that exercise? Do you think just because it's time consuming and cumbersome, or is there something else that they're kind of worried about? Or
I think part of it is just that comfort in being familiar with who you have. You know the ins, the outs. You know what you're going to get day in and day out. You kind of know I can expect this, and I don't have to worry about that. And so you kind of have that, fear of change, absolutely. And in many cases, you do have those vendors that have that relationship with the direct report with the hospital side that, it's a great relationship, and whether they provide a good service or not, they have that relationship. And so, really and truly for HHS and for us, that's why those relationships are important, but it's important to stay in front of the CEO and the COO as well. But if you're not reporting to them already, just because they're the decision makers typically,
right?
But really and truly, it's all about that relationship, and it's all about, I know what I'm getting. Do I really want to go through this? We picked up a partner, a large partner 2 years ago that had been with the same vendor for over 20 years.
Wow.
And it finally just got to the point to where they thought to themselves, there's got to be something better. And they went with HHS, and they're like, we wish we'd have done this 20 years ago. So it happens. So quite honestly, that's it. And they're not seeing all the costs. So it's typically you have someone beating that vendor's drum and saying, oh, yeah, they're doing a great job. And it's so much work to do something else. Quite honestly, now there's a lot of companies that are out there that will run the RFP process for the hospital. So,
right.
BPOs and such. Yeah.
Yeah. We're seeing more and more of that. So,
yeah. Agreed.
Well, and then of course there's some places where the board of directors does require you to do an RFP, and you have to in order to outsource. So, in those cases, it obviously makes sense too.
Yeah. Typically if it's
County
through
owned.
like a university or a school or
right.
It just kind of depends. That's a policy that a hospital can have or not have. So, but typically your university systems, we see that.
Right.
Yeah.
And
Funded
it makes
by
sense.
taxpayer monies.
You wouldn't if you get a medical opinion and you're like, well, I'm going to get a second medical opinion before I get this surgery. It's the same process,
Absolutely.
It makes sense. Completely.
Yes.
Right. You're so knowledgeable.
Yeah. Holy crap. Okay. So Ray, we are going to close out. We always try to close these out with something fun. And you're our first person at this attempt. So we're going to do with you the one or the other segment.
Oh boy.
Okay. You ready?
You got to remember, you got a conservative old man here. So.
Okay. But you have to answer quickly too, because that's the point.
Yes,
First thing
quick.
that comes to mind.
Okay.
Okay. We ready?
Ready.
Fruits or veggies?
Fruits.
Whataburger or Five Guys?
Whataburger.
H-E-B or Kroger?
Kroger. I don't have an HEB.
Oh, blasphemy.
He's justifying it to the Texan.
Yeah, that's,
I know.
That's
I was
exactly
like,
right.
oh my gosh, I couldn't live without my HEB. Okay. Cookies or cake?
Cake.
Scooby-Doo or Tom and Jerry?
Tom and Jerry.
Superman or Batman?
I like the dark side of Batman.
Batman, okay. 50s music or 80s music?
80s.
Sweet or salty?
Yes. Sweet and salty.
And the final one, long drive or long walk?
Long drive. Once again, the conservative old man with bad knees. I'm going to do a long drive. Depends on who I'm with. If I'm with my wife, it'd be a.
I was going to say that. There you go. A long walk on the beach.
Yeah, if she wants you to go on a walk, you're going to go on a walk.
True.
So, well, thanks again, Ray, for joining us. We really appreciated your time and your perspective and, everything you brought. So thank you.
My pleasure. Yeah. Enjoyed it.
I think the thing that I loved the most about that conversation with him was that it was super candid and it was talking about both sides of the aisle and understanding from the perspective of one, a support service, but also the administrator that's at a hospital.
Oh, yeah. And being able to see both sides and knowing, the pros and cons on each side really helps determine what's the best decision to make for the facility, which I thought was really cool. He was very objective about everything, which I liked.
Exactly. Well, thanks you guys so much for joining us for this candid conversation about popular misconceptions of hospital support services. We really hope you guys have enjoyed it.
Yes, and thanks again, Ray, for joining us. And thank you all for listening. We hope that you've learned some insight today.
Be sure to follow us and tune in for our next episode with another healthcare leader, wherever you listen to your podcasts. And for more tips in healthcare, follow the HHS blog at www.hhs1.com. Until next time.